Hey, and welcome back to another video discussion in the series. This time we'll be talking about deferoxamine, corresponding to Antidotes in Depth Chapter A7 from Goldfrank's Toxicologic Emergencies. The learning objectives are that you'll be able to explain deferoxamine's mechanism of action in treating iron toxicity and be able to outline a dosing regimen for it. With regard to the mechanism of action, deferoxamine is a hexadentate chelator of iron. Chelation has a specific meaning, which is more than just binding to a metal ion, but complexing with it through multiple sites within a single ligand. Each of these sites is a claw or tooth, which clamps down on the metal ion. Chelate is from the Greek for claw, while dentate is from the Latin for tooth. There are 6 such teeth in deferoxamine, so it's a hexadentate or 6-toothed chelator. Deferoxamine is clear and colorless in solution, but when it chelates ferric iron, Fe+3, it becomes ferrioxamine, which is reddish or pink. The problem with acute iron toxicity is that there's more iron than can be bound up to various iron-binding and iron-transporting proteins, resulting in free iron ions, and this free iron is causing the toxic effects. Deferoxamine scavenges the free iron, binding it up and limiting its toxicity, and the resultant ferrioxamine remains water-soluble and is renally cleared into the urine. Since ferrioxamine is reddish and is eliminated in the urine, deferoxamine treatment may result in a vin rosé urine color. The figure here shows serial urine samples collected from a patient with an iron overdose during deferoxamine therapy. And while this is a very interesting visual finding, that's all it is, just interesting. Historically, however, the presence of vin rosé urine after giving a test dose of deferoxamine had been used to indicate whether further deferoxamine might be indicated, or to determine when to discontinue deferoxamine when the vin rosé color went away. If a patient has acute iron toxicity and deferoxamine is to be given, it's administered by IV infusion. The recommended starting rate is 5 milligrams per kilogram per hour, and then to titrate up to 15 milligrams per kilogram per hour as tolerated. There is a rate-related risk of hypotension. And the infusion is continued up to a total maximum dose in the 6 to 8 gram range and for no longer than 24 hours. Prolonged deferoxamine infusions have been associated with acute respiratory distress syndrome. Awesome, this was another quick one. I'll be seeing you around.